Good evening to everyone and welcome to today's wonderful evening with Dr. Murli Bharadwaj. At least there is a relief that there is no next exam. So what is next after next? Next after next is NEET PG, which is inevitable. So that's the reason the same 150-day program, let us strengthen our pace and pitch towards the NEET PG preparation. Don't waste time on counseling, what may come, what may go, and all that, because that's one of the biggest time wastes, which we need to fundamentally overcome. So let's make the great beginning, Doctor. Can the online um, can you be able to punch? Is the voice loud and clear for all the online students? Yeah. So, doctor, how do we classify the closure of the wound and the healing of the wound? The wound basically heals by either primary intention or secondary intention. What do you mean by healing by primary intention? The wound edges are opposed. Suturing is done within 6 hours. There is a normal healing, minimal scar. That's called primary healing by primary intention, is what you should remember. Whereas, if the wound is left open, you let the granulation tissue to develop, make it to the granulation tissue will undergo contraction, epithelialization, but that lead to a poor scar. Then what is meant by healing by tertiary intention? It is also called delayed primary intention. Wound is initially left open. After 4 to 5 days, the edges are opposed. When the healing conditions are favorable, you call it as tertiary intention, is what you need to remember. So what you are seeing here, um, very good, loud and clear. Thank you for the uh, feedback, Altman and Jitendra. Absolutely right. No scar and scar is a differentiator, which you need to remember. So this is an example of healing by the primary intention. So clean, narrow incision, broader based wound, inflammation and proliferation is the feature of primary, whereas granulation and heals from the base is the feature of the secondary closure. Minimal scarring is the feature of primary intention, but wider and more visible scar is the feature of secondary. So once more, you also need to know what is a clean, contaminated, and the dirty wound. So all this video which I am now discussing is already there on the Score Learning app. And all these PowerPoint slides and 1200 pages notes, everything you will get by subscribing. But still, why I am reteaching the same content? Because just video is not enough. You don't get motivation. You need a little push from one of the classmates every day. And Dr. Murli Bharadwaj is that classmate who gives you all the time and energy needed to become something accomplished with the top rank. Now, doctor, let's talk about the sodium. What is the normal sodium value? 135 to 145. And how do you calculate the sodium deficit? So it is 135, which is the normal sodium value, minus whatever the patient's sodium value, plasma sodium value, into 0.6 into body weight, because 60% of the body weight is water. So 70 kg man will have 70 into 60% is 42 liters of water. So 135 minus whatever plasma sodium of the patient, this value, into 0.6 into body weight will give you the number of sodium, amount of sodium equivalents that you need to administer. Generally, 1/3 of the deficit is replaced in first 8 hours, second 1/3 in next 16 hours, and last 1/3 in the subsequent 24 hours is what you need to remember. What will happen? If you rapidly correct this chronic hyponatremia, it leads to central pontine myelinolysis, otherwise called osmotic demyelination syndrome. How much time does it take? It takes about 1 to 6 days of time, is called osmotic demyelination syndrome. Then, already we discussed what is meant by pseudo hyponatremia. There is no real hyponatremia, but whenever there is a hyperlipidemia, hyperproteinemia, hyperglycemia, or any osmotically active substance like mannitol, all of them will make the sodium become offended, smaller, and it looks like hyponatremia, but really it is not hyponatremia. So basically, natremia means what? Concentration of sodium. So it is a relative concentration of sodium in comparison to the other components in the plasma, that is lipid, protein, glucose, and mannitol. So whenever hyperlipidemia, hyperproteinemia, hyperglycemia, mannitol use is there, then relatively sodium levels will be low, which is called pseudo hyponatremia, is what you need to remember. I'm very happy to see 13 online classmates today's wonderful evening. Now, there'll be confusion, coma, decreased sodium, calcium, hypoosmolality, hypercapnia. All these are the features which you see whenever sodium levels are coming down. Now, doctor, let us take up a question. A 55-year-old alcoholic, history of liver cirrhosis, is being treated for hyponatremia. His sodium level is corrected too rapidly, and he develops acute onset quadriparesis, dysarthria, dysphagia. There are bilateral pyramidal tract signs, both sides Babinski positive. So what is the likely diagnosis? So you need to remember pons in the brainstem. So you have midbrain, pons, and medulla, right? These three are called brainstem. So pons is called the center for efferentiation. That is all the motor pathways which are leaving, right? They all pass through the pons. The moment the pons is affected, once it got demyelinated, then there will be bilateral pyramidal tract signs. Hatha Pava will not move. Hands, legs, everything paralyzed. He can't move at all. Dysarthria, dysphagia, acute onset of quadriparesis. Only movement that will be left is he'll be looking up, down, up, down, up, down. Only that is the only movement, because our vertical gauge is controlled by midbrain, whereas our horizontal gauge is controlled by pons. So whenever pontine myelinolysis is there, then there is a acute onset quadriparesis, loss of horizontal eye movement, conjugate movement, bilateral pyramidal tract signs, and also there is a acute onset quadriparesis. That's called locked up syndrome, which will occur whenever there is any acute correction of the hyponatremia. When do you call acute hyponatremia correction? Never correct hyponatremia more than 8 milliequivalents per liter per day. For example, 120 is the patient value. Your correction should not aim to make it 128. Only up to 128 you can correct, not above that. If you do that, then that central pontine myelinolysis will occur, is what you need to remember. Now, next question, favorite question in the NEET PG exam. 38-year-old female with a history of chronic alcohol abuse is brought to emergency with acute confusion, disorientation, horizontal nystagmus, gait ataxia, and there is a thiamine deficiency. What is the most appropriate next step in the management? So this is a typical triad of clinical features. So what is that triad? Patient has nystagmus, confusion, disorientation, gait ataxia. That is all the typical features of Wernicke's encephalopathy. And that is because of acute thiamine deficiency. That's the reason you need to give intravenous thiamine, is what you need to remember. So one more question we will take in relation to this for you to remember better. So Sir, does it mean sodium function is inhibited? Uh, is inhibited. So I could not get the question, Jitendra. You can post it back. Very good to see 15 online classmates. So to all of you, I like to tell you the secret of winning. Luckily, NExT is postponed. So we have the NEET PG now. The secret of winning any entrance exam, USMLE or the NEET PG is there are around 50,000 high yield facts covering all the 19 subjects. I created a 1200 pages notes of all these high yield facts and given to you. 3 spiral bonds. If you don't have, I will post it to you. There are 600 hours of video in the Score Learning app. Today only download it, Score Learning app, and also share it to your friends, right? And there are 40,000 MCQs that you need to practice. So all this is being provided to you, but just an app, a video library doesn't motivate you. What is needed? Every day we all meeting together, discussing at least 1 hour of subject so that you get the push to go back to the notes and go back to the Score Learning app and do the revision. So that is the whole purpose of Dr. Murli Bharadwaj spending the breath to inspire you to become the topper in the upcoming NEET PG exam. So please do come to everyday class, be part of our WhatsApp study group. Now, neurological examination shows bilateral abducens nerve palsy. MRI shows T2 hyperintensity in the dorsal medulla and lower pons. What is the most likely diagnosis? He received a treatment for hyponatremia, developed dysarthria, dysphagia, diplopia. So all these are pointing to watch. Only thing in this is hyponatremia, alcohol abuse is there, right? But hyperintensities are there in dorsal medulla and lower pons. That is the reason this is the lateral medullary syndrome of Wellenberg is what you need to remember. Now comes hypocupremia. Where do you see in Wilson's disease? Exclusively breastfed infants. Where do you see severe hypomagnesemia? Typically, hypomagnesemia, whenever the magnesium level less than 0.4, it's called severe. Often, hypomagnesemia is associated with refractory hypokalemia and hypocalcemia. Unless you correct them, hypomagnesemia, hypokalemia, hypocalcemia will not recover. That's the reason always whenever a patient has hypocalcemia, hypokalemia, you look for whether there is any associated hypomagnesemia. So what are all the conditions where patients can develop tetany? Tetany can develop in hypocalcemia. Tetany can develop in hypomagnesemia. Whenever there is a respiratory alkalosis or any prolonged hyperventilation also lead to the development of tetany is what you need to remember. Yes. Wujma, thanks for reminding. Yes. Now, sympathectomy. Let's talk about sympathectomy. What do you do in lumbar sympathectomy? L2, L3, L4 are removed. If it is bilateral, L1 is removed. That can lead to impotence because the failure of ejaculation. So, what are the various indications for sympathectomy? The favorite high-yield topic. Causalgia, any rest pain in Burgen's disease, ischemic ulcers, gangrenous frost, any symptomatic vasospastic disease, Plantar hyperhidrosis, because excessive sweating is because of sympathetic overactivity. Anhidrosis in Horner's is due to sympathoplegia, is what you need to remember. Then what is the contraindication to lumbar sympathectomy? Whenever there is any intermittent claudication, then it is because of the peripheral vascular disease. You need to address that. Lumbar sympathectomy is not the answer for the intermittent claudication, where it is a contraindication, is what you need to remember. 28-year-old female comes to the clinic with severe hyperhidrosis, excessive sweating, which is interfering with her daily activities. What is the most appropriate indication for sympathectomy in this patient is the question. Whenever primary hyperhidrosis is very severe, in such people, all their hands are wet, body is wet, face is wet, scalp is wet. If it is unbearable hyperhidrosis, then that is an indication for sympathectomy, is what you need to remember. So now let's talk about calcium. 40% of the calcium in the body is bound to albumin. So in hyperproteinemia, if you take hyperproteinemia, there's a decrease in both the total calcium and protein-bound calcium, but still ionic calcium is unchanged. That's the reason whenever you calculate the calcium levels, you want to interpret calcium levels, always interpret it in relation to the protein value, albumin levels in the patient. Because calcium is positively charged, albumin has anionic, negative charges, and calcium free ion depends on the level of the albumin. So that's what you need to remember. And typically, there is a drop of 0.8 mg per deciliter in serum total calcium concentration for every 1 gram per deciliter of the decrease in the serum albumin, is what you need to remember. This is one of the favorite calculation and question the examiner will ask you. So now, what are all the ions that control the irritability of the neuromuscular junction so that tetany will occur? Sodium plus potassium divided by calcium plus magnesium plus H plus decides the irritability. So hypernatremia, hyperkalemia, hypocalcemia, hypomagnesemia, in all this neuromuscular excitability, seizures, tetany, they're all the features, is what you need to understand. Now let us talk about the aneurysms, one of the favorite questions. SK is asking a very good question. What is copper? Wilson is copper overloadness, or how it causes low copper? See, cupremia is the level of the copper in the plasma. So whatever the overload of the copper occur in Wilson, it occurs in the liver. Because of the absence of ceruloplasmin, the copper gets deposited more and more in the tissues and less is available in the plasma. That's the point you need to appreciate. Hope SK could understand that. Now, what is the most common cause of aneurysm? Most of the times, aortic aneurysm is asymptomatic. When an elderly patient unexpectedly done ultrasound abdomen, you will discover the aortic aneurysm. It is asymptomatic is most common presentation. So most common cause is atherosclerosis in elderly lead to aortic aneurysm. In that also, infrarenal aorta is most common site for atherosclerotic and extracranial aneurysm, is what you need to remember. Now, if you look at the peripheral vessels, it is the popliteal artery, which is the commonest site of the peripheral arterial aneurysm, and most dangerous is rupture. Most common area where the rupture occurs is on the left side, retroperitoneal bleeding. Left retroperitoneal is the most common place where it undergoes rupture. Now, whenever you have aortic aneurysm, when do you need to repair a aortic aneurysm? Typically, when the aneurysm increases to more than 5.5 centimeters, then there is a risk of rupture of a abdominal aortic aneurysm is what you need to understand. So this is how you have a infrarenal aortic aneurysm here, and typically that has been repaired and a graft has been placed, and tomorrow day in and day out when you become a vascular surgeon, you'll be operating this kind of cases. Now, few most commons you should know. Most common site of abdominal aortic aneurysm, just before you have seen that, infrarenal is most common. Most important risk factor is atherosclerosis. CT angio is the investigation of choice, and treatment is only required when the aortic diameter is more than 5.5 centimeters. Okay, మీరు పంపియండి. Yeah. So there is a patient, doctor. I'll quickly see the patient and then once more we will rejoin. Okay, so just bear with me. Hi. So let us continue the uh, discussion, doctor. Abdominal aortic aneurysm, the most common site is infrarenal. Now, if you look at the aortic dissection, what is the most common site? It is the ascending part of the abdominal aorta, more common. Ascending part of the aorta, more common. Then, most important risk factor is hypertension. Investigation is MRI or transesophageal echo, especially if the patient is unstable, and treatment is Dacron graft. Yeah. So I'll just see the patient and rejoin, doctor. Give me 2 minutes break, please. Sorry for a short interruption, doctor. Um, yeah, we need to see the patients. Just now, I have seen a patient who is 25-year-old, alcoholic, and smoker with accelerated hypertension of 180 by 110. So always in young people, we need to look for renal artery stenosis, but there can be a predisposing factor of alcohol in this patient, right? So uh, you need to bear with me. One side, teaching is my passion. At the same time, seeing patients is my passion. So both the things I'm trying to create a balance, and that's the reason I'm teaching from OPD directly. So I work in this hospital called TX Hospital in Banjara Hills. So whenever you have any patient whom you wanted to refer or show for a video consultation, please do feel free, and I'll be happy to see and analyze the case and help out the patient. So now, doctor, what do you see here? There is a widening of the mediastinal shadow, which is called aortic dissection, is what you need to remember. So, how do you treat it? You will put a Dacron graft repair. Now, a 62-year-old male with a history of hypertension, sudden onset of severe tearing chest pain. This is how a question will come in the tomorrow's NEET PG exam. His blood pressure is 170 by 100 in the right arm and 140 by 80 in the left arm. There is a difference of more than 20 millimeters between the two arms. EKG show non-specific STT changes. What is the appropriate initial diagnostic test? We need to do CT angio of the chest. So sudden onset, severe tearing, chest pain radiating to the back, along with the difference in blood pressure between the arms, classical of aortic dissection is what you need to remember. Now, let's talk about metabolic alkalosis. So you should know, metabolic alkalosis occurs whenever the H plus ion is lost into urine. Who will make H plus lost into urine? Aldosterone makes H plus K plus lost into urine. So hyperaldosteronism is one of the causes. Conn syndrome lead to the development of metabolic alkalosis, because Conn syndrome is adrenal adenoma, which is overproducing the aldosterone that will make sodium potassium lost into urine, and that lead to hypokalemia. Then typically, if you look at the electrolytes in case of metabolic alkalosis, high potassium, low chloride, hypokalemic, hypochloremic, metabolic alkalosis. Where do you see? In pyloric stenosis, thiazide diuretics, gastric outlet obstruction, prolonged vomiting. So whenever pyloric stenosis or a prolonged vomiting or a gastric outlet obstruction is there, the patient is vomiting the acid in the stomach. That is one reason leading to metabolic alkalosis. One more reason is typically the patient, whenever he is prolonged vomiting, gets dehydrated. That decreases the plasma volume, renal plasma volume, that will stimulate the aldosterone release, and that in turn will lead to the development of caliuresis and H plus loss into urine. Both of them will lead to the development of metabolic alkalosis, is what you need to remember. Now, a 45-year-old female with history of chronic vomiting, bulimia nervosa, presents with pH of 7.5, bicarbonate of 32. This is a classical story of metabolic alkalosis. So what is the cause? What else is associated with this metabolic alkalosis? Along with H plus lost into urine, aldosterone will also make K plus lost into urine. So caliuresis along with aciduria is the combination you see whenever the metabolic alkalosis is due to secondary hyperaldosteronism. due to decreased renal plasma flow because of the low plasma volume, because of the chronic vomiting, is what you need to remember. So now let us talk about the anion gap. So what is normal anion gap, doctor? Normal anion gap, 10 to 12 millimoles per liter. 10 to 12 millimoles per liter. So there can be metabolic acidosis with normal anion gap or metabolic acidosis with high anion gap. So normal anion gap metabolic acidosis is called hyperchloremic metabolic acidosis with normal anion gap. Whenever there is any diarrhea, cholera, small bowel fistula, ureterosigmoidostomy, in all these things, one side there is a loss of bicarbonate, another side there is a rise of chloride. So bicarbonate is negative ion, it falls. Chloride is negative ion, it increases. So when bicarb falls, chloride increases, together will not alter the anion gap. So such kind of hyperchloremic metabolic acidosis is called normal anion gap metabolic acidosis, is what you need to remember. So whenever normal anion gap metabolic acidosis is there, you need to look into what is the underlying cause. For that, you need to look into urinary anion gap. Suppose if the urinary anion gap, how do you calculate urinary anion gap? Urinary sodium plus urinary potassium minus urinary chloride will give you urinary anion gap. If it is negative, wherever the urinary anion gap is negative, that means the cause is the gut, not the kidney. It is extra-renal. But if the urinary anion gap is positive, then it is renal. It can be type 1, 2, or 4 renal tubular acidosis. Then look at urinary pH. If it is more than 6, then it is type 1 renal tubular acidosis. But if it is less than 5.5, then it can be, if hypokalemia is there, it is type 2. If hyperkalemia is there, it is type 4 renal tubular acidosis, is what you need to remember the algorithm. So now, doctor, 25-year-old female with history of type 1 diabetes, laboratory studies show serum bicarb of 18, serum chloride of 112, urine pH is 6. What is the most likely underlying cause of her acid-base disturbance? So once more, this is a question of normal anion gap metabolic acidosis. Here it is renal tubular acidosis, because salicylate toxicity, lactic acidosis, DKA, they're all the causes of the high anion gap metabolic acidosis, is what you need to remember. So doctor, with this, let us take a call for today. And thank you all for joining the session. रोज मिलेंगे, रोज पढ़ेंगे, एक दिन कामयाब होके दुनिया को दिखाएंगे कि भाई मेरा नंबर आ गया है नीट पीजी में बोल के. All these videos earlier also discussed and all made available in the Score Learning app, doctor. Today only subscribe and do the revision every day with Dr. Murli with you. Thank you.